what is heart failure? Heart failure essentially is a term that we use when, technically speaking, there's not enough oxygen consumption or delivery to the heart. And then also there is fluid accumulation. And we can go into the details of it because I don't want to belabor you with all the terms. So first we have to recognize what it is, fully understand what it is, and try to improve our wellness approach as well as our dealing with it from a multidisciplinary angle. And then eventually, if we don't understand sickness, we're not going to be understanding wellness well. So we really have to understand the disease process itself, deal with it, and then how to kind of change our thinking behind this whole strategy of wellness. So the contents of my program include scope of the disease, the epidemiology, the basic diagnosis, management, and some novel treatments, which I will not belabor you on. So the burden of heart failure, as Ram had mentioned, 25 million people, number is going to rise. It sort of doubles every 8 to 10 years, and there's more, unfortunately, more people that are hospitalized, and we want to reduce that. Mortality from heart failure after diagnosis in about 5 years is about 50%. And that's quite significant. And there's a huge economic burden of heart failure around our communities, not only in the local hospitals, but also in the outpatient setting. So there's definitions that we sort of get into. There's kind of a busy slide, and there'll be a few other busy slides, but I will try to simplify it. So heart failure, essentially, as I said, there's not enough oxygen delivery to commensurate with the requirements of the tissues or the metabolism. And then the pressures can vary up or down depending on the kind of heart failure we have. So heart failure relates to something that we define in simplistic terms as a pump function of the heart. So if it's a normal pump function, we call it preserved ejection fraction. Ejection fraction is the amount of blood that is ejected per second. And there are certain ways to calculate that by echocardiography that Dr. Anjali Gulati will sort of explain a little bit more in her talk on videos. But then there's the non-preserved ejection fraction, which is called reduced ejection fraction, where the pump function is in disarray and the heart's not pumping well. So we calculate a number less than 49 to be a more kind of impaired function. And then there's other terms, left heart failure, right heart failure, and so on, which I won't get into because in the interest of time, it would be rather difficult to kind of go over this. We can do that in the Q&A. The diagnosis of heart failure can be difficult, but essentially in terms of awareness from a patient's perspective, in terms of the symptoms, shortness of breath is the cardinal feature when people get short-winded or short of breath with either mild exertion or even at rest. Fatigue, tiredness in conjunction with some of these, it's not just being fatigued causes heart failure, it's a combination of symptoms and a syndrome. Reduction in exercise tolerance is a very important point to remember. And then a lot of people say, well, my ankles tend to kind of swell, or I can't exercise like I did before. Those are things to be sort of be vigilant about in terms of heart failure in itself. Now, classification, and again, complicated slides, but I'll try to simplify it. There's the American College of Cardiology and American Heart Association on the left side, which talks of the screen, which talks about stage A, B, C, and D heart failure. And then there's the New York Heart Association classification on the right-hand panel of the slide, which talks about class 1, 2, 3, and 4. That's a New York Heart Association, also adopted by the Canadian classification and also by the Indian Heart Association. So that being said, however you stage it, stage A is when people have absolutely very minimal symptoms for heart failure, and they can exercise a fair amount without getting tired. Stage D is when you have on maximized medical therapy having symptoms even at rest, and B and C are in between. Same way, 1, 2, 3, 4 match A, B, C, D. Multiple causes, as you can see, and I'm not going to belabor you on all the causes, from congenital to cardiac arrhythmias to outside the heart disease called pericardial heart disease, or high output states, which are very common, by the way. Anemia is a big contributory factor, as is on the myocardial front, coronary disease, hypertension, and a weak heart called cardiomyopathy. So I will jump into the next slide. It has a detrimental effect, and this is an important slide for all of us listening in, that the quality of life really gets messed up. You know, people get depressed. There's mental problems with hostility, anxiety, because it's a chronic condition. And there's limitation to daily activity, which is very, very important in terms of trying to lead a reasonable life. Reduction in sexual activity, and then disruption from work, because people get short-winded all the time and you just can't focus in your work, and that's a real problem. And then in terms of comorbidities, any of these diseases that has been outlined here and also talked about by Ram just before this, diabetes can contribute to this, hypertension, chronic angina, kidney dysfunction, you know, gout, hyperlipidemia, iron deficiency, anemia, and then even disturbed sleep. Obstructive sleep apnea, for example, can contribute to it. So I'm going to jump into the next slide here, next slide group here, which talks about the prevalence and then diagnosis. The diagnosis of heart failure is based on a staged process. You assess the risk, you diagnose the patient. I'm talking about it from a cardiac and a non-cardiac perspective, from a doctor's perspective. You detail the workup, and then you you figure out the underlying cause or etiology, as we call it. And that's done by basically clinical assessment, biomarkers, a BNP, which is the brain natriuretic peptide, which is released from the heart, interestingly, by the stretch of the heart, whether it's the right side of the heart or the left side of the heart, particularly the left side of the heart. That marker is very important and critical in diagnosis of heart failure and in follow-up. Echocardiography, stress test, and so on. There's multiple other ways to diagnose. Cardiac MRI has become a very important tool in diagnosis of certain types of heart failure. And then there's invasive testing, which I won't belabor you on. So diagnosis essentially depends on a number of factors, and BNP measurements can certainly help in diagnosis. So morbidity, I mean, this is an important slide, you know, relative what I shared with you earlier in terms of how do you reduce fatigue? How do you reduce breathlessness? How do you reduce hospitalization? How do you improve quality of life? Those are things to be sort of thought about, and we need to kind of discuss that in our Q&A sessions. And then this is probably the busiest slide I have, but talks about the types of treatment goals, from drugs in class A or stage A to stage B, where you have more drugs and now implantable devices called implantable defibrillators, to stage C, where you require remodeling of the heart, again by some forms of pacing called biventricular pacing, besides drugs and defibrillators. And then you sort of talk about the last stage, which is really cardiac transplantation and sort of chronic inotropes, as we call them. Finally, how do we sort of try to target improving life and improving some of the symptoms? You know, anemia is correctable, iron deficiency is correctable, COPD can be managed, although it's hard, but it can be managed. Changing habits for liver and bowel dysfunction can be handled well. Treatment of diabetes is quite prevalent now with, you know, chronic glucose monitoring and so on and so forth. Depression, mental health is required in part of this management as well. And of course, coronary disease management. So the stakeholders in this, and this is a very critical slide for those who are interested in staying focused on this particular part of the presentation. Essentially, it's an interaction between the patient, the primary care physician, the cardiologist, and the heart failure group that includes a heart failure nurse and a heart failure physician. And then there's the patient's perspective, right? This is what patients sort of always sort of like to see. That's, again, a very critical piece of information for those on this call. You assess to care, and the therapies that have to be equal. In other words, they have to be sufficient, but they also have to be, you know, patient wants treatments to be equal across the board. Better initial management of patients and self-management, speeding up recovery to help self-learning. That's important because we have all our websites to check all of that, but you also want to see you have good interaction with your providers and your clinicians. And then one of the big problems is when people bounce in and out of emergency rooms, how they're dealt with. You know, people are often said, no, you don't have heart failure, but you actually may have it, and it could be subtle, so it needs to be well sort of sought out and be preventing hospitalizations for that reason. And these might be my last couple of slides to kind of engage you in the different disciplines again: early diagnosis, prevention, treatment optimization, education, telemedicine. Telemedicine has become very critical in heart failure management, especially for ongoing chronic care where there can be a multidisciplinary approach, but also um, in instructing patients fluid balance, reduction of salt, discussion around treatment measures and other tools. Lastly, I want to talk about the Oxford Forum, which is kind of critical. I'm sorry, the slide is kind of off a little bit, but basically talks about how do you prevent heart failure, how do you ensure quality of care, and how do you promote support and empowering of patients. So those are the questions that remain unanswered to some extent, but I think that there's a continuum going on in this process. So I'm going to take it to Anjali now, who's going to demonstrate and show you some other videos that would sort of get you to the point on heart failure management. Anjali, off to you. If you have your videos, that would be good. Thank you.